this is a good time to think about biological breaks, I think we now call them in Zoom land. If you've raised your hand, please take it down, because I don't want to see any raised hands, because I'm going to ask them in a minute. So Greg Milan, Letitia Cross, Andrew Humphreys, please take your hand down, so I know that that's not just left there from earlier. Otherwise, I'll assume it's just left there from earlier. So for the next 5 minutes, I'm going to open the floor. So all hands are down. So our guests, you're free to go. Thank you very much, but stick around if you want to. You're all free to go to a kettle, but just stick around for a bit of chat too if you want to. Thanks, Jackie. Thanks, Rachel. Thanks, Chris. Thanks, Michael. Struth. Let's see. Who's got a hand? Who wants to ask something of the room, contribute something? Letitia Cross, you're first. Go ahead.
Hi guys, I just wanted to talk about momentum is very key in rural and remote areas, and it's challenging to maintain when funding and PHN funding is often piecemeal in this sector, and I'm interested to know the panelists' thoughts around that.
Anyone want to respond to that on the panel?
One thing that I would respond to, Letita, is that is very much the case, and I think that is very concerning, given that the federal government funds us and that like flows through to our funding timeframes, but our capacity to invest in the future as well. So I know definitely with our work being a trial that we have to build sustainability in, and for us it was developing pieces of work that we could find a home for in a sustainable way. So local council is often a good place for that. But also part of suicide prevention is helping the community to be part of that change. So building sustainability and within the community to take their own responsibility alongside service delivery and funding bodies. So I think that was one of our messages was, you can help yourself, but help a mate as well with the men's health lunch, because I think we can't be propagating the idea that a service system will fulfill your needs. It's about community fulfilling and being part of the solution as well. So that would be my response. Yeah.
Letitia, my response would be that that mirrors the introduction of primary health networks in our country, that there was a rapid transition, a significant responsibility with limited finance. I guess it highlights the important role of the integration and coordination of the system of care as a key priority. And I would encourage, so in Western Victoria, we have worked with the organisations that are being contracted to deliver services. We have worked with them to extend the contracts to the end of, in terms of June 2022, to really, in an authentic way, be able to co-design with the funding that's available in tandem with the regional mental health and suicide prevention plan. The foundation plan is just about completed, and now will be the implementation of our regional plan. And that's a joint responsibility between the state local health networks and the primary health networks in our area. So that will help understand the experience of piecemeal approach to make it to drive a more thin basis in our region. So it's a really good point, and one that we're well aware of.
Thanks to the panelists for the responses there. So I'm going to hand over in a second to Jonathan Bedlow from Men's Resources.
You already see an excellent dentist.
I'm going to heckle from someone there. Please mute the mic.
It's hard to see with someone else, but after all, I canceled the date.
Yeah.
My birthday, and it's time.
That's really interesting. I hope Mick's got all over it. So I'm going to hand over to Jonathan Bedlow in a moment. Jonathan's from Men's Resources Tasmania, one of our member organisations, and also a long-serving former board member and former president of the Australian Men's Health Forum. Jonathan will be chairing the next session starting at 11:45 and keeping this conversation going for those who want to participate. So I'm just going to ask if there's some questions that Mick's dropping in the chat box there, Jonathan, and also I'm going to just ask one more time if people want to raise a hand to ask a question. I'm just going to take one more hand if there's anyone that wants to, or make a point. Otherwise, we'll take the question in the chat box. Not getting any hands there. So one of the questions that we had from earlier was, and it was around, I think from your talk, Mick, if he's still on, but anyone can take this or join in, is, I'm going to throw this into the room and then walk away. Is it more acceptable for men to present angry as the narrative around men and emotions? Is it that it's not okay to be vulnerable? We know that underneath the anger is significant sadness. So just some thoughts on why is it more likely or more acceptable that men present as angry? Anyone want to take that?
If I could make a first response, Glenn, just before I do go, I do have to leave, but I don't think it is. I think at certain times it may present like that, and that it's difficult to sometimes work past that and unpack that. So it's not about being acceptable. I think the idea of men learning to interact with more constructive, or to interact more constructively is absolutely paramount, because we know that when it's dysregulated, we know the statistics around violence and family violence and domestic violence, of which men are more often to be the perpetrators. So it's not about being acceptable. It's about trying to work through in a non-judgmental way about how to engage beyond that, to build skill sets that are more constructive and designed to get better outcomes for everybody.
Thanks, Michael. Jonathan here. I had a thought around that as well, and I wonder if it's whether sometimes men themselves perceive it to be more acceptable to be angry rather than vulnerable. Whereas, of course, at the service end of things, it's absolutely not acceptable for them to be angry, and there's a lot of work to say, no, if you're going to be angry, then there's no place for you here. So there's a paradox there, opposing forces.
Yeah.
Anybody else have any thoughts on that?
The only point I would make around that is I don't know that men or people, not just men, but people choose anger as an expression of themselves. I think is an unconscious pattern that iterates throughout their lives to certain points, and that they regress to in moments, or create patterns that are regularly communicated in that way. So at an unconscious developmental point, I think that's an iteration from childhood through to whenever a man is presenting or seeking help or responding in a situation. So to undo that and unpack that and change that is a significant challenge once the patterns are formed, but is very, very possible and very doable with the right access to the right techniques and strategies and ways of managing things in a better way for men and women.
And how do I hear them?
Yeah.
Well,
Thanks. So, Greg, did you want to make a comment on that? Nice to see you, by the way.
yeah, it's nice to see you, Jonathan. Just picking up on what you said, yeah, obviously anger isn't going to get anybody very far in our health and welfare system, so I'll get closed down. I think men and women too, but we're talking about men, have trouble with a range of difficult emotions. That's how I put it. So we should be helping men to deal with a whole range of what I call difficult emotions, like sadness, grief, anger in there, happiness sometimes in there, a whole range of things. And we should be, focusing on that. that's why I think we're a little bit over the anger management movement, I hope. But by taking out one emotion and trying to deal with that on its own kind of doesn't make any sense to me. That's not the way I operate. I think it's about upskilling and supporting men with how they deal with a whole range of emotions.
And dare I say as well, helping services work with how do I actually take a man who's angry and help him get in touch with the underlying issues.
Sure.
That training end of things as well, yeah?
Yep, for sure, yeah.
Okay, so it's coming up on 11:45, 11:45, where we're about to start our session. So thanks to everybody that's stuck around with us. Hope you've enjoyed the morning so far. I wasn't able to be part of that discussion, but certainly sounds like it's ended in a good place. So I'd like to just take a moment to acknowledge the traditional owners of the land on which I'm meeting, which is the Nuanona people here in Nipaluna, Hobart, and in the land of Lutruwita, Tasmania. So thanks for having me on board. It's a pleasure to be chair of the session today. So this morning we're going to hear from various people who've worked with primary health networks around Australia. I probably should just check that we've got everybody on board. I know Anthony Hart is with us from Save Our Mates. Nice to see you,
Right.
Anthony. We're also expecting Samina Allam and John Davis from Launceston. Are you on board?
Unmute. Hello, we're here.
We're here. Living the dream.
There we go. Nice to see you both. Thanks for joining us. And also Jeremy Forbes from the HALT organisation. Jeremy, are you with us? We might give Jeremy a few more minutes. He's going to be one of the later speakers as well. And Glenn Paul, of course, is also part of this session. So, folks, we might delve in. We've got lots to get through, I'm sure. I'm sure there's plenty of great content to be shared from our various speakers. Just to introduce you to start with, Samina Allam and John Davis are involved with the Launceston City Council, also here down in Tasmania. Samina Allam is the local suicide prevention coordinator for the Launceston Suicide Prevention Trial Site. Samina has a graduate degree in public health and has worked in various health settings across Australia and internationally. Her interest lies in creating healthier communities through the development of primary prevention initiatives. Great to have you with us, Samina. And also, John Davis is the Community Development Team Leader for the City of Launceston. John's been working in various community development roles for the last 20 years and has a particular interest in working in partnerships to develop strong and resilient communities. John is a member of the Launceston Trial Site Working Group as well. Great to have you with us, and we might hand over to you two to share your insights and inspiration.
Great. So you want to try and get the share up?
Yes. Share screen. All right. So what we might do is share our screen. If we can get it up.
Yes, you're both our hosts now, so you should be able to share whatever you've got. If you have it open first, be good. We might suggest that you come a little bit closer to your computer microphone too.
Okay, we'll try that. Okay. It does get a little bit like that. So we're in a meeting room.
Yeah.
Maybe while you're just getting settled, I should just give people a bit of an overview, a bit more of an overview of the session as well. So the way we're going to run this session is we'll take, I believe it's 10 minutes for each set of speakers or each speaker to give us their, share their experience of working with PHNs. and that will leave us some time at the end for some more general questions and answers and a bit more discussion. So I'm going to pretty much hand over to each speaker. I'll introduce each one as we go, and we'll go from there. Just by way of a brief bit more introduction to myself, I am with Men's Resources Tasmania down here, and I played a role with the trial site working group here in Tasmania to really try and get men on the agenda of the various trial sites here. So that's my connection with this side of the work as well. All right, looks like we're ready to go there in Launceston, so I'll hand over to you, John and Samina. Thanks very much.
That would be Samina and John. I'll hand over to Samina. There you go.
All right. All right. Thank you for the opportunity. This is always really fun, sharing what we've learned, and obviously we always feel like we're on a steep learning curve. So bear with us as we go, and please ask questions as we go along as well. It's just going off. And I know the angle of the camera always sounds a bit off, and we've been told it looks like people are viewing in on us as if we're in a jail or something, because the camera is so high up. So it's always a funny angle. Okay,
great.
All right, so we are going to share our experience of working with the PHN in Tasmania as our commission service. And for PHNs, we've literally got the only one, which is Primary Health Tasmania. So it is going to be us sharing our experience of working with them, a little bit about the project that we've been working on, which is the suicide prevention trial, and some of our learnings from there. Yeah, so I think we've done the introduction, so we're not going to be talking too much about that. We might just go into the whole trial. So let us give us a brief about the national and then Tasmanian suicide prevention trial. So the national, and I think a lot of people might know this already, but we do have 12 sites across Australia. So that is being federally funded. And each of these sites are looking at a different cohort of people. So within those 12 sites, Tasmania is considered one of those sites. And the Tasmanian one, which PHT, so Primary Health Tasmania, has the funding for, and they've broken it down into 3 different locations. So Launceston is one of those trial sites, and each of these trial sites have their own host organization. So the Launceston is hosted by the City of Launceston. We have one which we call the East Coast or the Break a Day. So that is hosted by St. Helens Neighborhood House. And one we called the Northwest collectively, which is basically 3 local governments, which is Devonport, Central Coast, and Burnie. And Relationships Australia is hosting that. So that's all 3 of these different trial sites across Tasmania. Each of these trial sites have their own working group. They have their own I guess policies that they look at as well. And they have their own action plans. So each of these trial sites have looked at what is important locally, and we've all created our own action plan to focus on what's working well and what can we do differently in terms of that. But I guess the commonality between all of these 3 Tasmanian trial sites is our target population. We're looking at men aged 40 to 64 years of age and any person above the age of 65 and above. So that cohort of people is the same across all 3 trial sites. For our trial site, or the Launceston trial site, we've sort of focused it geographically in the northern suburbs. When we say northern suburbs, we basically mean 7 suburbs in the north of Launceston.
Correct, and those particular suburbs are relatively low socioeconomic areas on the whole, and they are also regarded as a fairly high risk population for mental health and suicidality.
Yeah, and the trial basically it ends in it's been extended for another year, which means that we're now finishing up on 30th of June 2021. So that's the last lot of extension. This was quite a surprise, I think, for all of us involved, including PHD, that it has been extended for another year. But this one is more about looking at, I'll get the chats function. Okay, it's not. Okay, so it's good to have another year to consolidate what we've been working towards. So I've got a picture of our working group there, and that's not the whole working group, just a couple of members. So we've been working obviously with Primary Health Tasmania, and Primary Health Tasmania has actually been a very, I guess, unique position in the Launceston suicide prevention trial. So they've had two roles. One is they are obviously the funders of the suicide prevention trial, but also they've been working as our working group member, as a representative on our working group member. And it's actually been really good. Sometimes a bit confusing, I think, but I think we've worked through that, and now I think we're working really well. Yep. So a few things, I think Primary Health has been absolutely very supportive of all the work that we've been wanting to do, looking at some of the local needs for Launceston. And in terms of implementing some of those activities that we wanted to do, we found that there has been not barriers, but some difficulties in implementing them. And Primary Health Tasmania has been extremely understanding and supportive of that. And we've tried to find ways of how we can, I guess, bypass or overcome some of those challenges. And they've been really good in giving us some of those advice and sharing their knowledge as well. And it's always been really good communicating with Primary Health, because they've been very good with clear communications and flow of information, I think.
Yeah, they've demonstrated a real flexibility in working with us rather than acting in that fairly traditional funder-fundee arrangement that you often see. They've been very much willing to be in more of a partnering role through this process, which has made for a much better relationship than some of the others that I have been involved in over the years, but also there's been a lot of trust that's been created, I believe, between our organisation, the council here, and Primary Health as we work through these through any issues and matters together.
Yeah. All right, so we'll move on, and just a little bit more about what we've been doing or how we've been doing our work. So we have been using the Lifespan Framework by Black Dog Institute. So you can see that wheel there. We have about 9 strategies that we've been working on. A few of them have been, so the whole point of the Lifespan Framework is we want to reduce the number of suicide, obviously, but we found that it's often, and working with University of Tasmania as well, who are one of the local evaluators, it's become very clear that often it's really hard to correlate that the trial has had a direct impact on reducing the number of suicide, because suicide is so complex. It is hard to say 1 or 2 factors have led to the reduction or increase of suicide. So what we've been doing as well is, obviously we want to reduce the number of suicide as well, but we want to reduce the impact of suicide and suicidality in our local communities. But we are also focusing on building the resilience and capacity of our communities. We've had a fair bit of, I guess, a number of suicides within the community, and people are still sort of coping with that, but also in terms of how can we be more proactive in reducing suicides in the first place. So looking back at the wheel again, some of them have been really easy for us to implement in terms of a local council, because we work with communities, being a part of the community development. It's been easier for us to implement some of the bottom ones. So training the community to recognize and respond to suicidality, the bright green one. The orange one, engaging the community and providing opportunities to be part of the change. So those are the good ones that we've worked very well with, and also the dark green one. So promoting health seeking and mental health and resilience. Not in schools, because we're not really working with the cohorts who go to school, but building resilience in the first place. All right. And I'll give you a little bit of more snapshots about some of those general activities. So we talked about training. So we had a lot of fair number of gatekeeper training. So we've had Safe Talk, Assist, course training, OzHelp, and Mindframe. So these are all local communities or local organizations who we've partnered with to deliver some of those gatekeeper training. We've also focused on talking safely workshops. So how do we talk safely about suicide and mental ill health in our communication? So how do we talk about it? How do we write about it? And we're doing a lot more about that. Pathways to care. So now that is an interesting one, because if you look at the model again, it doesn't really talk about what do you do after there's been a suicide. But for us, we thought that that is in fact a gap for us, and we need to be catering towards that. So the Pathways to Care, we've run 2 sessions of those by standby, and it's been very well received. So we have speakers from different ambulance, police, and they talk about what do you do after there's been a suicide. So that was very useful as well. Out of the Shadows, again, a really good one. This is the first time that we run one in Launceston. We have that every year in Burnie, in Hobart, but this was the first time that we did it in Launceston. Advanced suicide prevention training, so working with GPs in that. This one we are extremely happy about. We had a lived experience training with Roses in the Ocean. So we identified people with the lived experience of suicide. Roses in the Ocean, we commissioned them to come and run the training, and all the people who've gone through the training are now part of our working group. So they have been very actively giving us advice, working to implement a lot of those activities as a part of our action plan as well.
That actually added a real dimension to the working group, because it was we're actually having people that could have eyes from outside and act as critics of what we might be doing, and saying, look, I don't see how that could work. I don't know why you're doing it this way, and actually calling us to task a little bit around some of the plans that we had, because they were able to see it from the inside out.
Yeah. So that's basically some of the general ones, but we'll focus in some of the male suicide prevention activities that we've had. So male suicide prevention community forums, which actually Glenn Poole ran twice in Launceston, and that was very well received, because the way we've been approaching some of our suicide prevention activities, and it was good to, I guess, rethink how they can cater to men, because you know, I think, for example, working in emergency services, we know that might actually not be a really well strategic place to be working for men, because men use more lethal means, which means they don't actually end up in emergency departments. So those were some of the really good learnings from there. We also had gatekeeper training, which Glenn Poole ran. We had suicide prevention for older adults. So again, that's very different to how you would approach middle-aged men. We had Movember, and I have got a picture at the bottom there. So these are our local council staff members who've championed the Movember in our workplace. We also have the Blokes Book, which we've partnered with Men's Resources Tasmania, and we're doing using the Blokes Book as a mean to reach some of the more grassroots level. And happy to say that Mowbray Golf Club has requested 200 copies of the Blokes Book, which means that, you know, we're finally reaching into the grassroots level. And Stories of Hope, that was for
sorry to interrupt, Samina, just want to give you about a minute to go.
All right, we'll smash through this, don't worry. Okay, so just a snapshot of some of the working group and partnerships that we've had, and we've quite a few of them. And what's coming up? So we're still, and when I was putting the slide together, I realized we're actually doing a lot more with the men. So we're doing a mental health first aid, and we're partnering with Open Arms. We are doing something different. We have a Marooned, which is a suicide prevention play. We're also working with Dr. John Lane to deliver gears for first responders and safety planning workshops. So again, that all depends on when the borders start opening up. So some of the successes of working with men, I think working with MenShed, so working with some of the peak bodies. We've also, I guess, made partnerships with some of the male-dominated workplaces like task force. We've had local champions who have picked up some of these activities, and obviously some of the internal workforce and training. Working with men, I think the challenge always is they're very hard to reach. So reaching some of the grassroots level, and we're still sort of working in that. Conflicting priorities for individuals and organizations. I think everyone's got a lot on their plate, and they're almost always doing it off the side of their table. So that's always been a bit of a challenge for us. limited time and capacity of individuals, but also from a local perspective, I think male-friendly services have always been a bit of a challenge because we don't have a lot of after-hour services, and also the fact that most of our doctors are not bulk billed. Yeah. They don't bulk bill. So anyways, that's our last slide. So we smashed through that.
Well done.
Yeah.
Thank you so much. There's so much going on up there. It's fantastic to see. So look, you're able to stick around, I'm sure, for the rest of the conversation. And I'm sure there'll be some questions that people would like to raise. So we'll save those. And for the moment, we will move on to our next speaker, which is Glenn Poole. Of course, everybody knows Glenn as CEO of the Australian Men's Health Forum and Director of Stop Male Suicide, a man who's doing fantastic work in so many different ways. So thanks so much for everything you're doing, Glenn, and we'll hand over to you.
I told people in training, make sure you unmute your mic before you start, and I've just done the classic thing myself and didn't unmute the mic. There we go. So I also need to start my video. There we go. Have you got me now? Great. Okay. Yeah. And I think I can probably share my screen. Yeah, I can. So look, I'm shifting hats here because I'm facilitating today as the CEO of the Australian Men's Health Forum. But one project I've been working on before working with AMHF and continue to work on is a project called the Stop Male Suicide Project. Now, I had hoped that in this session we would have mates in construction who have been doing work in Brisbane North, which is focused on using community sports clubs as a way of engaging with men. So those of you, some of you may be familiar with the mates in construction model, which targets male-dominated industries like construction, mining, engineering. They're doing a pilot with Brisbane North PHN, which is looking at how they can translate their model to a community setting using sports facilities or sports clubs as the starting point. They weren't available today, but they are going to present on that next Tuesday at an event that we've got on men's health and sport. So I really encourage you to come along to that. About 3 or 4 of the projects already referenced today, Sons of the West in Melbourne, the Active Breed Bulldogs project in southwestern Sydney, and the, I think, SALT training down in Melbourne too, as well as the Mason Construction project, all being showcased next Tuesday. So I really strongly encourage you to come to that. So I'm a kind of last minute fill-in for Mates in Construction. But I have worked with 3 PHNs on male suicide prevention. So really what I wanted to do was share my journey, coming from the perspective of someone who wasn't from a large organization, was clearly passionate about and focused on male suicide prevention, but didn't have a great sort of backlog of evaluated programs because was trying to do something new and innovative that wasn't based on what we were already doing. So the background of the Stop Male Suicide project is that when I arrived in Australia from England just over 5 years ago, I had a broad men's health background and had worked with a particular charity in the UK called the Campaign Against Living Miserably, CALM, CALM UK, which was one of the first charities, well, certainly the first charity that I ever came across that was specifically focused on male suicide. Dates back to the late 90s, sort of millennium era. Managed to get some funding from government to target youth male suicide in the Northwest. Started off from the perspective that young men don't access mental health services, so it's no point in improving mental health. This was their logic. No point focusing on improving mental health services because young men aren't showing up there. So we need to go where young men are, and very much built relationships through like club culture, the music scene, the comedy scene up in the northwest of England, starting in Liverpool, and grew quite extensively to the point where it's now a national charity. There's a lot of really smart kind of public campaigning, but also behind all that public campaigning, there's a what you might call more male-friendly helpline than perhaps sometimes the average Lifeline or Samaritans in the UK, is because the callers are almost entirely focused on taking calls from men, whereas traditional helplines, maybe 40% of their callers are men. So did have a background in men's health and some interest in some experience in male suicide. And basically I was just looking at, well, where can I be a contribution to the men's health sector in Australia? And it really seemed that a particular focus on male suicide was really called for. And my partner and I were based in Sydney, but just about to jump in a motorhome and hit the road for a couple of years. We saw that as well as an opportunity to see this wonderful country, and also to test the strength of our relationship. Because if you want some relationship advice off me, it's this: if you want to test how strong your relationship is, go and live in a very small tin box on wheels together for 2 years and see if you still love each other at the end of it. I'm pleased to announce that the answer is yes, we still do. And we had a wonderful time in the process, as well as many challenges. One of which was how to run a series of statewide seminars whilst traveling through the outback. But we managed to do it. We managed to hold a forum in every single state and territory around the country called Stop Male Suicide in WA or Tasmania or Victoria. And the idea was really just to provide a platform that brought together people who were already doing work in suicide prevention or already doing work in men's health, and try and find an overlap. Because whilst there are a few people focused on male suicide specifically, my premise was this: that there was a load of really passionate people in the suicide prevention sector, but who didn't necessarily know a lot about engaging with men. And there's a lot of really passionate people in the men's health sector who are really great at engaging with men, but didn't necessarily know all the ins and outs of suicide prevention. So the Stop Male Suicide Project was trying to build a community at that interface, the overlap between the suicide prevention sector as it is now, and also the men's health sector. And then that built lots of knowledge, lots of information. We found lots of people coming forward some people were coming forward and saying, well, how do we engage with men? How do we stop suicide? Others were coming forward and saying, look, we know what to do. We do it on a daily basis. We're out in the field. We're meeting blokes. We know what works. We just wish more people would do it. And so I found there's a lot of knowledge already out there, and we tried to synthesize that. And one of the things I noticed, the next gap I noticed was that, now let me say this, my false assumption when I first started that project was that I diagnosed the problem slightly wrong. I was looking at the statistics: 8 suicides a day, 6 men, 2 women. And my assumption was the reason that we're not doing more about that is because we don't care enough about blokes. And then what my experience was, as I took the conversation around the country, was that people care passionately about blokes, because blokes are their dads and their partners and their sons and their uncles and their brothers and their mates. And there's a whole world of people around Australia who care passionately about male suicide. Just often, they don't actually know what to do. And so there's that: I really care about this issue, but I don't know what to do about it. So, one of the things that's been mentioned a lot today is gatekeeper training, and there's lots of gatekeeper training out there, and I've done most of it, and it's all very good in different ways, and pretty much none of it puts any focus on gender. You can go and do 2 days of assist training, which will give you loads of guidance on, how to spot people who are suicidal, how to have, really meaningful conversations, how to be bold and ask the question, but none of it focuses on some of the differences that we can utilize between men and between women, and how we can utilize those differences to actually engage with men more effectively. And so we developed, based on previous training that I'd run about how to a training called how to stop male suicide, which is essentially gatekeeper training, but the difference is we spend the whole day focused on engaging with men and the different pathways to suicide that men take, right? So,
Glenn, we need to, we've got about a minute to go. If you,
sure.
Yep.
So, so basically, the first time I really delivered that training in any sort of detail, because I delivered it to groups of 3 or 4 around the country, was when Eastern Melbourne PHN commissioned us to deliver 4 sets of training. And we got to deliver it to 20 people. And it meant we really began to learn how well that worked and how people responded to it. From delivering it in Melbourne, we were able then to go to Tasmania, where we've delivered it to a few hundred people. I'm just going to quickly share screen to give you some of the. Excuse me. See if I can share my screen. This is 2 slides, so I will do my minute. I'll smash through it like Samina. So here's an example of 5 days of training that we did across different sites in Launceston. 5 sites, 5 days. One of the things about our suicide prevention training is we found that in mainstream suicide prevention training, 70% of people who do the training are women. So there's 2 things here. One is about getting more men trained to do suicide prevention training. We think that's really important. So 57% of people we train were men. And the other is to get people focused specifically on male suicide. And you can see from the before and afters there that we're shifting people very quickly in a day. And there's just some of the feedback. Now, the thing I will say, there's a phrase I've heard, and I think it's a good note of warning. We can't just do train and hope. We can't just train people and then hope that that will solve suicide. And for me, what I'm interested in, I mean, Launceston City Council helped me start to do this, is how do we build relationships with the community over time? So the community forums followed by training is something we did in Launceston, and it will be my last point, Jonathan. And so what we've now been able to do, before COVID kicked in, unfortunately, it's been put on hold, but we're now working with Hunter New England Central Coast PHN with a year-long project where we're not just doing training, but we're looking at building a long-term relationship with the community. And it's a specific community. It's because we're targeting older male suicide. So it's people who are in contact with older men. And yes, we're going to train them, but also it's about building relationship with them over time, over a year, bringing as much expertise about older male suicide into that PHN, and then not just looking at how we shift people from people's knowledge and confidence from 9 a.m. to 5 p.m., but what kind of shift we can make at a community level from July to June. So that's a very brief snapshot of the Stop Male Suicide Project and some of the work we've been doing.
Fabulous. Thanks very much, Glenn. Great insights there, and fantastic stats there on that last slide as well. So as always, there'll be an opportunity to direct some more questions towards Glenn at the end. We'll carry on with our various presenters, and I'd like now to introduce Anthony Hart, who's Director of Save Our Mates. Anthony's a passionate social entrepreneur and advocate for mind health, and a man on a mission to shift the narrative around mind health in Australia. He inspires, activates and educates his audiences to join a new movement that nurtures positive support for those suffering from depression and anxiety. Anthony, great to have you with us. Over to you.
Jonathan, thank you. So the business I lead is called Heart Wellbeing, and so one of our major projects that we did, commissioned by the PHN, was we got approached to do some regional roadshow tours across, I'm from Adelaide, South Australia. If you know the map, there's the legs, there's York Peninsula and Eyre Peninsula. Hayley Conyer and Shay Kerno from PHN approached me to work through a program to do a series of 17 talks across the York Peninsula and Eyre Peninsula. We came up with a name called Save Our Mates, and they were a community wellbeing night. And so we picked all the major towns, Whyalla, Port Augusta, Port Pirie, Port Lincoln. We went to the top of the York Peninsula, and they were male dominated. We had females come as well, but mainly male participants come, and we put together a professional roadshow where we had speakers on each of the legs. So we went over a 3-month period to give consistent messaging. We went in the first month of February 2019, we went from town to town and did 5 nights in a row, Monday, Tuesday, Wednesday, Thursday, Friday, starting at the top of York Peninsula, Maitland, going to Port Pirie, Port Augusta, Whyalla, and finishing in Port Lincoln. We had some great speakers. So we had Jeremy Forbes, had Joe Williams, Warren Davies from the Unbreakable Farmer, and I spoke on the first leg. So we did talks to about 800 people over the 5 nights, and it was to share stories surrounding lived experience of people who had gone through serious depression, anxiety, or suicide attempts, and just to normalise and share open stories with communities. So working with PHN, at the start, the policies and the procedures are very strict, and it really helped our business get off the ground and start to have disciplines around procedures, protocol, and systems. My professional background for 15 years prior to that was in pet retail. So I've come from a family business. We own the 8 stores in South Australia for Petstock, which is a national brand. And I'd toured guys like Dr. Harry and Dr. Chris across our 8 stores. And so it was the same type of process that I used to roll out the roadshows across the region. So look, I really enjoyed it. I'd like to play a very short video. We got a camera crew that the PHN paid for to film the first roadshow, and I'll just get everybody, I believe, to pin your video on your screen, and you'll be able to see it. Go pin me on the video. It goes for about 1 minute and 10 seconds.
Men traditionally don't like to talk about these sort of things, so it's just encouraging guys, especially, to start to speak up, and not only speak up, but notice the behaviours in each other, so we can put our hands out and help each other.
Hi, I'm Anthony from Heart Wellbeing. Stigma's terrible around this issue, and it shouldn't be. Mental health is the same as physical health, meaning that if you've got a problem with your arm or your leg, you go and get it sorted out. But with a condition with our mind, we've still got this problem about getting help. This is one of our biggest key goals by sharing these stories, is to get rid of that myth and make it feel safe for blokes to get help.
Just the thought that, and everyone needs to know that, there's ways of fixing things. We just need to open up and start the first steps of wanting help, asking for help, and then there's ways to fix it.
So, look, the first roadshow was one of the best things I've ever personally done in my life. I've got such a passion for people not getting early signs of being stressed, not getting into such a bad spot that they think about taking their life. And that's what happened to me 17 years ago. We worked really well with our reporting. We engaged a media agency to do the PR, and we had meetings with the PHN after the first roadshow, which was in February. We got some really good feedback, very direct but very good. It made us go back and look at our systems, because with security and procedure around mind health and people who are coming to these talks, we have to be absolutely world class. We then did the second roadshow with a different group of speakers, and it went really well. A couple of lessons, I suppose. The security on the night. So if any attendees left the talk, we would straight away have someone from the standby suicide team who would go out and follow them outside. If anything was missed, one of us would go out and just intercept and just make sure that that we'd acknowledge that there was something that they'd heard in the talk that might have triggered something, and there were counsellors there on the night. 6 months later, we did another region roadshow. So first one was called Save Our Mates Community Wellbeing Night. The second one was across the Riverland, and that was with Chloe Osterbrick. And we called that Look Over the Gate, Save a Mate. And we put a picture of a female and a male looking over a gate. And that was a mix of male and female. And so we had a female speaker who was very powerful, and we had 2 male speakers. So that was across Berry, Renmark, Loxton, Waikerie. And whilst the attendance numbers were slightly lower, we had really good reach across the whole region, and we followed that again up 4 weeks later. So there was one drive through of the 5 towns, and then there was a second one about 6 weeks later. So what it did was it got the message out that if you missed the first one, and the word would spread that they were good nights, there was a barbecue, there was, you know, there was good conversation, and it wasn't a confronting, I'll call it eyebrows down or depressing night. It was very uplifting. Safe language is always used, and we did the second road show, the Riverland, in November 2019. So yeah, that's my experience. We really enjoyed it. We significantly have resourced up during COVID-19, and we've taken on 2 more people from an administrative capacity point of view. And the business that I lead is full-time now. It's a passion of mine to get out there in community, share these messages, and reduce, you know, the stigma, and also to give people tools and tricks and tools for how to confront stuff better. So I think that's just about me, Jonathan, on
No worries.
10 minutes. If you've got any more time, I can certainly go on a bit more.
That's fine. Well, let's leave it there, and we'll save some more time for some questions. I'm sure there'll be plenty of them coming shortly. Thanks very much, Anthony. Fantastic presentation.
Thank you.
So we'll move on to Jeremy Forbes, who's a tradie in Victoria, who founded the Hope Assistance Local Tradies Project, or HALT as it's known, in 2013 after the suicide of a fellow tradie in Castlemaine. Jeremy is a Victorian painter and decorator by trade, who now works to raise awareness of mental health among local tradies. HALT is now in the process of becoming a national program as well. And Jeremy, he barracks for Collingwood. Geez, bold man, willing to make such a claim. Loves military history and bushwalks in winter as well. Jeremy, thanks for being with us, and I'll hand over to you.
Thanks, mate. Can you hear me all right?
Sure can.
Great. Thank you very much. Yes. Where do I start? You've given a nice little breakdown there, but let's just weigh in. As you alluded to, I'm a tradie, so painter and decorator. So what the basis of HALT is that lived and shared experience of mostly men in the building industry, and what that culture has what it's like and what it has driven me to become. So I was part of that culture for a long time, that tradie culture, that you'll be right, she'll be all right, a cup of concrete and harden up, don't be a princess, all this stuff, be stoic, be strong, don't talk. That's what I was a part of. When I moved to Castlemaine in 95, because I was a bit naughty, I had to get out of Melbourne, moved to Castlemaine, that culture was the same. And the risks that we experienced, the bullying, the harassment. I've bullied and harassed people. I've been bullied and harassed. It's jokey, it's blokey and all that. And I was still part of that. And what we need to realise, everyone out there, is that that's what we know. So for blokes, it's not, our usual response is, if we're struggling or a mate's struggling, is you'll be right, she'll be right. It doesn't make us a bad person. This is all we know. As apprentices growing up, this is all we know is you'll be right, she'll be right. We're not encouraged in that culture to reach out or emotionally engage with the blokes. So 2013, we lost a tradie in Castlemaine in Central Victoria, where I am. I've been here almost 25 years, and we're at the wake. Yeah, I know it's very tragic, and we're at the wake in a small community. And are we actually going, hey, do you know what we should do? We should get together and we should help our mates. We should break through this. No, there was none of that. It was, who's next? Like, seriously, who's going to suicide next? And I'm sorry, but that's the reality of conversations out there. So I got a phone call from my co-founder, Catherine Pilgrim, who said, let's do something for the blokes and the family. And she said, great. What are we going to do? I don't know. You ask the average tradie or blue collar worker out there where to go and get help. And I can guarantee you they virtually have no idea. They have very little idea and actually how to access the help, how to go, how to have the conversation. So we said, something's got to change. We need something different. And the community in Castlemaine was calling out for it. So we started Halt with not a single cent. So nothing. We went to the local butcher and the baker, and we went to the local coffee house here, and we got all this stuff donated. We got Rotary involved, and we had an event. That's not enough. Having an event is not enough. We need to have the services there to show these, mostly men and women though, where to go to get help. So for us, that very first event, we had Lifeline there, someone from Lifeline, and when I become Prime Minister, I'm putting it in the Constitution. They get full funding as much as they want for Lifeline. We had Bendigo Community Health along as well to talk about their support services, and that's continued. We did an event in Castlemaine, got about 40 or 50 tradies. I spoke about my experience. We went to Bendigo and Mitre 10 or whatever it is, Home Hardware. And then we got into TAFE. So you want to talk about change, and these tradies, people go, tradies are tough. Yeah, you scratch the surface and they start talking. So we did an event at TAFE for the apprentices, because the apprentices, when I've talked to hundreds of them, thousands around Australia, and they talk about risk factors, finance and relationships. They're learning nothing about that in TAFE. They don't know about financial counselling or relationship counselling, or they've demonstrated social behaviours can be averaged from family. So it's about that. And since then, fast forward, I've done a TED talk that you can watch if you all want to go to sleep, and that's great. But we've done probably maybe 1,000 events over 5 years. We've worked with Country SA, PHN, which I think is that way, and WA, which is that way, and up north, and Melbourne, and all that sort of stuff. And we just existed. Halt was, we're a health promotions charity now, but we needed to lift this up. We needed to bring this up, because what's out there for blue collar, what community engagement, suicide prevention support is out there for the blue collar workers? I don't know, you can tell me, please. There's not a whole lot. So for us, Halt, we recently, in December 2018, we met with Federal Health Minister Greg Hunt, and he was very supportive of the work Halt was doing. Halt was just me for 5 years, just traveling around Australia, doing what I could just on the smell of an oily rag, but we needed to lift this up and build a national program, yeah? So that's what we did. We met with the Federal Health Minister, who did a wonderful message for us the other day on video message, which was awesome. We met with Greg Hunt, and he said, okay, go and approach the PHNs you've been working with and ask them to submit for funding for a Halt worker. So that was great. We went to Southeast Melbourne Primary Health Network, and we went to Northwest Melbourne Primary Health Network and Murray PHN up in my area in Castlemaine, Bendigo, and basically said, this is what we want to do. What do you reckon? And luckily enough, a couple of them come through and decided to go with that. So we're currently working with Southeast Melbourne Primary Health Network down on the Frankston, Mornington Peninsula, Dandenong, in through there. We've got 2 Halt workers there. We've got 2 Halt workers in the Northwest Melbourne PHN, which is awesome. We've got a worker over in South Australia working over there, and we've done some work with Murray PHN. So we're working with the PHNs. We got 2 million over 4 years, which is great, and we're very grateful for that. We'd eventually want Halt workers working with every PHN out there. Where do we work? Where do we work? We work at hardware stores at 6 in the morning. We're not governed 9 to 5, I can tell you that. That does not work. So we work at hardware stores, trade stores, TAFEs, men's sheds, local council depot, sporting clubs, factories, CFA, police. We have a whole of community response. Our workers are out there in community running events and linking all these tradies and blue collar workers in with support services. Why do I emphasise support services? Because that's where the PHN comes in. That's where Southeast Melbourne and Northwest Melbourne have been fantastic, because it's about collaboration. It's about them understanding what we do, us understanding what they do, and Halt has these things called Halt-friendly clinics, yeah? Because what happens is blokes go, we can't see the doctor. There's no psychologist. There's an excuse there. We're taking that out of their hands by doing Halt-friendly clinics. So they're clinics that understand what Halt's like, what tradies are like. They have the double appointment, And at all the Halt events, we try and have a worker there. We try and have a psychologist or a doctor or a counsellor at TAFE and all that sort of stuff. So that's where the PHNs have been working really well with Halt, and they're working with Rachel Earle and Beth Dangerfield down in southeast Melbourne and their crew to get those Halt-friendly clinics recognised through that area. So as far as PHN go, what can we do for you? We can do events. What can PHN do for us? Well, we want to access your allied health and your doctors and your psychologists and get out there and promote the work Halt's doing in the community. We're doing heaps of work. We're getting evidence and evaluated over 3 years by Swinburne Social Research Institute. So we're going to have evidence and evaluation. We're going to report coming and June 15th. We're aware of that. So that's great. We're getting evidence by them. And that's what we do. So that's what Halt does. It's a whole of community approach, which is needed. And it's about not walking into a community and going, hey, look, we're going to do an event, then leave. You know, it's about resilience and building knowledge and experience and education wherever we can, and bringing everyone together. Because I can tell you, we're having, you know, it could be 6 o'clock, it could be, Glenn talked about sporting clubs. So we do a lot of footy clubs on a Thursday night, you know, 15 minutes after training, that sort of stuff, which is huge. But we need, when we work with the PHNs, is to work across the whole of community, not just be specific. So the PHNs have been really supportive with that. Hey, you know, seriously, we're still learning what each other does. Halt's a bit different. We get that, but we talk about innovation and needing to do something different. We need to be out there before 9 a.m. and after 5 p.m. So yes, there's discussions happening, but we're starting to understand each other, and we're hoping really, and I'm probably just almost out of time, is that I'm hoping that, you know, when we get when the next lot of funding comes up, yeah, why not? Here we are. I've got PHNs here. I want to work with Gippsland. We're in the process of trying to work with Gippsland PHN. I'm doing a heap of stuff in Geelong. We're doing stuff across communities in Australia. Next funding cycle, we want the PHNs to come on board and say, we want a Halt worker. We want someone dedicated to be working in our area for our people full time. So yeah, there's been some challenges, but nothing we can't overcome. So I think that's, Jonathan, was... Yep. My list.
Well done.
So thank you.
Thank you so much. Such a great story, and I know I've heard it before, but it's just so great to see your passion and your commitment to the work. And clearly, it's getting some runs on the board in the areas that you're working. So thanks so much, Jeremy.
Thank you.
So just before we go to some Q&A time, I just want to come back to Anthony briefly, because I diddled him out of a couple of minutes there, really, and I thought maybe he's got a couple more points to make. So Anthony, a couple more minutes. What else would you like to add?
Look, I think that I've written 3 things down. Whoever's dealing with PHN or anyone else who's giving you funding, you know, work on your business. After our first roadshow, we did a very extensive operations manual, and then after the second roadshow 4 weeks later, we pulled it to bits, and we thought, can we run the next roadshow if we get one, based on what we've just written? So version 2 came out, and we then did another roadshow to the Riverland, and I went on all of the first 3 roadshows. I physically went on myself. And it wasn't until the 4th roadshow that I was able to stay at home and delegate down to an ops manual with, I had a lady on the ground working the 4th roadshow. So number 1, operations manuals and procedures. We'd come from a franchise background, so pet stock was very disciplined. You couldn't stuff up anything, and you had to have the pricing right, you had to have the dog food in the right spot, and it's easier to comply. Right, and so you get better scalable outcomes if you can comply. We can roll out roadshows all around the country now. It doesn't matter where it is. We've got the same process. And number 2, don't be a jack of all trades. And the PHN were great. In our quotation, we actually put down, we outsourced all the media to a PR agency. Now, that wasn't cheap, but we went with 2 quotes. We spoke to the PHN about the funding level. We went with the middle of the road company, and they did all the phone calls to the radio stations, TV stations. They planned all the interviews. All that was done. So don't try and do everything. And the third thing, I talk about reports and feedback. So, you know, we were proactive to ring up our contacts at the PHN and say, can we please have a meeting to not get grilled, but yeah, pull us apart and tell us which bits weren't quite right. And you know, if I could have a fourth point, is to work with really good speakers, passionate speakers. Like, you don't have to be the best speaker in the team, but like Jeremy Forbes, we have a great time. Can you have fun doing these roadshows?
Yep.
I think we can. Jeremy and I love it. We go around and do the 5 towns and we get so pumped up and we take so many questions, and it's the passion of the speakers. So get the right speakers, get all your processes right, and don't try and do everything yourself.
Fantastic. Thanks, Anthony. Great points there at the end to finish off our time, a lot of time with our speakers. So, folks, from here, we've got a bit of time, about 20 minutes for some questions and answers. And I know there's a couple of questions that have been raised in the chat. Hopefully we'll get to those. If you have a question and you just want to know how to get yourself some attention, if you go to the participants icon in the bottom of your screen and click on that, that'll open up a box on the side near your chat box, and you can raise a hand in the more. There's a little icon with more underneath it. No, that's not the right spot. Somewhere in there you can raise a hand, and that's how we'll take your questions, or by all means put your questions in the chat. So we'll wait for a couple of those to arrive. Some of the one learning or one experience that I've had through my journey with the PHN. So as I mentioned at the start, I was on a working group that was formed by our local PHN here in Tasmania to really scope out what the trial site projects might be, where they would be around Tasmania, look at some of the demographics. And I think from my perspective, I think it was really critical having someone there at that table, at that high level table, who could bang the drum about the stats around male suicide. I don't believe there was anybody else that would have had that same message at our table. And so I just want to add that in, that if you can get someone who understands that those stats at that policy or sort of project formation level. Pete Schmiegel, you know, from AMHF mentioned yesterday in a session that the political end of things, you need to have some certain processes, but I think also at that policy level and at that strategic point of developing the project, if we can get people in there with that perspective, that can really help. All right, enough from me. Any questions from anybody that they would like to raise? There was a comment back there about PHNs being refunded, and a question, I suppose, about whether that's the best use of those funds. I guess those funds they are put into the PHNs, so whether that was a good idea or not, in a way, another question. But I guess, what would some of our panelists say? You know, what can we do to take advantage of that fact that it does have another year's funding?
Yeah, Jonathan, I'd jump on that. I saw that comment. It was kind of like a positive comment, in the sense it was saying that, you know, there's some really great people in this room. Why aren't we sort of like, you know, putting not just this session, the previous session. You know, why aren't we putting more focus on that? Why are we refunding the PHNs? Well, like you say, the refunding's already happened, so it's on one level it's an academic question, but you know, there's pros and cons about the whole PHN model. There's pros and cons about the whole lifespan model. My biggest criticism of the lifespan model was that it didn't specifically name gender as a, and it's not just a gender thing. I know, for example, I heard advocates for LGBTI communities sort of saying, look, the model it just deals with improving the interface between the existing services. It's not addressing the underlying social issues. The model isn't really focused on those broader social determinants that different communities actually experience. But the fact is, the way it was funded meant there's some priority populations were named. And the massive thing that made the difference in terms of male suicide was at the initial point of funding, and this goes back to the point you were making as well, Jonathan, was that although the model didn't mention men, at the point of funding the pilots, men were identified as one of the groups that would be targeted. And that is actually revolutionary, because most suicide prevention policies, most suicide prevention funding is gender blind or gender neutral, but really it's gender blind. I mean, gender neutral, let's be specific. Gender neutral means that, we don't take account of gender, and it's okay because it doesn't make any difference, right? But gender blind means we fail to take into account gender differences, and therefore, in the process, we miss out on opportunities to help not just men, but women and people of diverse genders and diverse sexualities. So suicide prevention historically has been gender blind, and that's what's been missing, because what we need, I believe, is gender specific and gender inclusive approaches. Gender specific, targeted at different gendered groups, and gender inclusive, ideally, not just like, let's focus on men to the exclusion of women, but let's take gender inclusive, let's take into account lots of different gendered approaches, and let's take into account lots of different approaches to working with targeting male suicide, for example, not just one singular approach. So the very fact that the government said men need to be one of the target groups means that we're having this conversation today, because it means that lots of PHNs actually started to wrestle with the challenge, how do we target men? And we would not be having this conversation today if that point was not made 3 years ago. But we need more people advocating for men at more tables, like yourself. I sit on the expert advisory group to the PM's advisor, Christine Morgan, and I'm banging the table about male suicide there. But there's lots of tables where decisions are made where men aren't on the agenda. And you can see that in the National Suicide Prevention Strategy. It's not the plan. The fifth National Mental Health and Suicide Prevention Plan, it doesn't specify men. So it's a positive thing that we've had the PHNs, because it's actually meant that the health system, for the first time possibly, in any significant way, has started to wrestle with how do we actually target men. So if that continues, and then we start to have conversations like this, that's great. Can we do more? Can we do better? Can we do it faster? Yes. But we are where we are, and I think compared to 3 years ago, it's actually very positive.
Thanks, Glenn. So, any other experience? I'm wondering if there are other people in the overall session who've had their own experiences with PHNs. Anything anybody would like to share? Stick up your hand, or even just jump in, unmute yourself and make a comment.
Hi, it's Gareth Daniels here. Can you hear me?
Hi, Gareth.
Hi, I'm from Rockhampton, Central Queensland. One of the good things that I found PHN in our area is putting funding into creating suicide prevention plans for the different areas, which have been shaped for the different towns. So, we'll say for Rockhampton, which is very different population to Emerald, which is a different population to Gladstone, sort of thing. The plans are being made appropriate for those areas. And one aspect of that is looking at specifically suicide issues, suicide prevention around with regards to men. And the services that could be provided, many of which have already mentioned, such as the construction sites, as in mine sites, sporting fields, and different areas like that. So I think the PHN, being a local PHN, has been able to really look at the local needs in that area.
Thanks, Gareth.
I wonder if I might just comment about Chris Jones' earlier presentation and the Southwest Sydney PHN and my own personal experience involved with some of the work they've done on the co-design session and planning models for suicide prevention, specifically for men, and taking up your comment, Glenn. That suicide prevention network really does appear to have a very, very good grip on what is needed and how to go about targeting a specific and unique set of outcomes and listening to the community about how to get around that. I just thought I'd comment.
Thanks. We'll take that as a comment. All right. So I wonder if we don't have any other questions being urgently asked, I don't think, but please do jump in. If people have one, just open your mic and jump in. But I'm wondering, maybe just to go back through the panel briefly, what recommendations do you have for those that maybe haven't engaged with their local PHN, or hasn't been projects specifically targeting male suicide prevention? What recommendations would you have to those people to go about that process?
Can I take that one, Jonathan, to start off?
Yeah, sure.
I think there's not a lot of grassroots suicide prevention programs and projects that have kicked off and gone national, but I can guarantee you there are so many out there that are grassroots, men, male, whole of community, the INAT, Jeremy Edwards with INAT in Whyalla, and they're doing work and they're saving lives. They're talking to people. You know, I want to see them sort of engaging with PHNs and replicating that. I want those people in the grassroots suicide prevention organisations out there to get in contact with me, get in contact with Anthony, Greg, yourself. We're here to help mentor you. Well, sorry, from my point of view, is that I do that. Is that any of those organisations want mentoring around how to negotiate, how to work with, how to collaborate with PHNs, because we see where the rate's going, and it's going to get worse, and we need something innovative, something different, yeah? And there's, whether it's the Trademark Boys, it's INAT, there's so many out there that are doing amazing work that we should be throwing money at to replicate, to get out there and improve. I think they should do it. They shouldn't be overawed. PHNs are there to help. Yes, there's collaboration and negotiation and understanding from each side. I get that. But if they've taken a chance with Holt and they've invested, they'll do that with others. So please don't give up. Reach out to us to help you through it. And you'll find that the PHNs are accommodating and you can get in touch with them. So that's what I think.
Yeah. Thanks, Jeremy. And just to echo that grassroots approach that you mentioned at the start, you know, getting a real bloke like yourself who's out there on the front lines in the tradie sector or whatever the sector may be. Doesn't matter if you say a few things, you know, that are not quite exactly right initially. It's a work in progress, eh?
Yep.
Yeah. I'd just like to support, I can't always be Jeremy, but yeah, pick the phone up and ring your local PHN representative and actually just put your hand up and have a crack. You know, guys like, well, certainly Jeremy's got resources over there. We've got resources in our business that can actually facilitate. We can't do these workshops and these roadshows without speakers and groups. So it doesn't matter who gets the project. We have to build up a relationship with PHN. So whether it's Jeremy gets the contract or we do, every contract we get, Jeremy's always a speaker, right? So, and if there's other speakers out there, we need to know who they are, because then we help them help us. So it's it's a collaboration. And I think, you know, the more groups that can set up those structures and treat it like a business, because it is a business. If you guys can operate your operation so that there's process, procedure, there's insurances, there's just like if you went to a tyre shop or a restaurant or a BHP, you know, all these businesses have got processes and structures, and it enables us to be able to scale. So, yeah, put your hand up.
Thanks, Anthony. Samina and John, do you have anything you want to add?
Yeah, for sure. Thank you for that, and thank you for the presentations too. I've really enjoyed being a part of it today. One of the things that's really come to light over the last couple of years with what we've been doing has been the raised awareness of the different factors that drive male suicidality as compared with female suicidality, but also older male suicidality compared to younger male. And so this has been a really strong learning for not just for the people involved in the trial, but for the broader community. I mean, we've with a lot of the gatekeeper training, a lot of the sessions that have been done, a lot of the community groups that have been met with, the whole focus has been on learning just how different people cope with the different stresses in their lives. And some of those stresses are completely, they've come off the wall for me. And how is that a possibility? And when you're looking at with the elderly men, a lot of the drivers for suicidality there are around the family issues and wondering whether they're even wanted around whilst their kids are squabbling over who's going to get the inheritance, you know, and those types of conversations and those types of things are really making people take stock of the way that they speak, the way that they talk about the elderly. Men are becoming a lot more prepared to talk, and people are talking in the sessions that we're having, and we feel that there is a reduction in the stigma around talking about mental illness, about talking about the worries that you're going through, about just getting out there and chatting. And it's okay for blokes to feel and to chat.
Yeah, and we've moved away from that medical model that, you know, mental health illness is one of the reasons that leads to suicide in men. And having Glenn Poole run some of those sessions has really turned it on its head. So I think we've moved a lot away from that mental health, from that mental or clinical perspective to more of a more social aspect of there are other things in men's life that can, I guess, push them towards thinking about suicide.
Yeah.
Can I bounce off that, Jonathan?
Sure, yeah.
Just say thank you for the acknowledgement, Samina. It was really great, you know, working with the Launceston community and just like having a conversation to start off with, right? Not assuming we have the answer, but having them a more. I love doing awareness training, but it's great to do that more conversational approach. And just sort of like explore what solutions might be from that perspective of the that particular community, the people who show up and say, we want to solve this, and get them engaged and meet them where they are. And so for me, I think I'd like to flip the question on its head first and say, I'd really like to see more PHNs embrace that, to trust men, to give the men in your community ownership of the problems. You know, and obviously all the caveats around the right way of approaching that, but you know, men are not in the health system as much as women. If you look at just one really simple thing, if you look at the community reference groups for every PHN, or often like the suicide prevention steering group, it's mostly women, not men. And so, like, you know, you can argue about why that is. Is it wrong? Is it right? Is it men's fault? Whatever. But the fact is, it is that way. And so then the onus is on you as a PHN to actually ask yourself, how can we reach out and engage with the men in our community and open the door and say, look, you know, we're interested in exploring the solution with you, because we do need, obviously it's a whole of community issue and it involves men and women, but we do need to facilitate ways for more men of different backgrounds to take ownership. You know, people like Jeremy, people like Anthony, you know, people, I mean, and you need to take those people on a journey and not expect to meet them at a point where they have all the answers and they're all super professional and they've done all the training and got all the accreditation. Actually take the men in your community on a journey with you and see who steps up as a leader and support them. And from the other angle of saying, you know, how do you engage with your PHN? Well, we've got to find ways to get more men more people advocating for men, whether that's men or women, into those networks and systems. So we need more men on community reference groups. We need more men showing up at community events. We need more men on steering groups, banging the table and saying we need to focus on male suicide here. So it's a two-way process, but see your PHN as a potential partner, not as an enemy who's doing it wrong. Because something I've really heard in this conversation is the willingness to learn. Going back to John Semina's initial presentation, they were working it out as they went along as a commissioned service and had to keep going back to the PHN and saying, well, what about this? And also people they were engaging with were actually challenging them as well. It's like, when you're arguing and making people wrong and saying you shouldn't do it that way, you should do it this way, there's no space for growth and collaboration. So let's give each other a bit of slack and actually, accept that a lot of men don't know all the right way to talk about suicide or have the mental health training. But let's also accept that PHNs and health services don't have all the answers when it comes to male suicide. And let's find a way to get in conversation and learn together. Because where that does happen, you see great projects emerging over time.
Thanks, Glenn. I just wanted to add one brief point before we wrap up, and that is that the lived experience speaker, we're probably used to having lived experience speakers in the big community events, but there's a place for them in those steering committees as well, to actually, bring home that real story to that particular context. I'm mindful that there's another session following us up, so I really want to thank all of our panel members, Samina Allen and John Davis from Launceston City Council, Glenn Poole, CEO of AMHF and Director of Stop Male Suicide, Anthony Hart, Director of Save Our Mates, and Jeremy Forbes at Holt. Thank you all so much for your sharing of your wisdom and experience. We really appreciate it, and I want to encourage our viewers and our participants to stick around for a session, I believe, connecting in with people from the Black Dog Institute. Glenn, I might hand over to you to let people know a bit more about that. Thank you all very much.
So thanks. I'm swapping my hat now and I'm going back into chair mode. So thank you, Jonathan, for chairing that so well.